Thank you very much for the kind invitation and for the introduction. My presentation will focus on the role of PCSK9 and PCSK9 inhibition in non-alcoholic fatty liver disease. This disease, since 2023, has officially a new name, which is metabolic dysfunction-associated steatotic liver disease, or MASLD. It is the most common liver disease worldwide, with a prevalence of approximately 25%. MASLD is very strongly associated with common metabolic risk factors, in particular obesity, type 2 diabetes mellitus, and the metabolic syndrome. The spectrum of this disease ranges from pure steatosis with mild or no inflammation to steatohepatitis with mild or moderate fibrosis to advanced cirrhosis and end-stage liver disease and the development of hepatocellular carcinoma. Only a small proportion of patients with MASLD will develop end-stage liver disease and complications of end-stage liver disease. What it is important to keep in mind is that one of the most common causes of death in patients with MASLD is cardiovascular disease, and more specifically, ischemic heart disease. And this is the reason that the international associations recommend a more holistic approach to the management of this disease, which includes not only management of the liver disease per se, but also of the metabolic comorbidities, including hyperlipidemia. Hyperlipidemia is very common in patients with MASLD. The risk is double compared to the general population, and hyperlipidemia in this population is atherogenic. It is more common in the early stages of the disease, whereas when the disease advances to progresses to more advanced stages, the lipid profile usually normalizes. The treatment of hyperlipidemia in MASLD is similar to the rest of the population, and the mainstay of treatment are statins. Statin therapy reduces cholesterol synthesis, and this leads to reduced hepatic cholesterol content. Statins have been shown to reduce hepatic steatosis and to improve some parameters of this disease. PCSK9 is a molecule that plays a role in LDL homeostasis. Its physiological role includes binding to the LDL receptor on the membrane of the hepatocytes, and this binding induces the degradation of the LDL receptor. And this leads to less cholesterol uptake by the hepatocytes. This is the molecule, the PCSK9 molecule, and the red part is the domain that binds to the LDL receptor. PCSK9 also binds to the VLDL receptor and CD36. CD36 is a fatty acid scavenger receptor and plays a crucial role in the pathogenesis of steatohepatitis in MASLD. The binding of PCSK9 to the CD36 receptor is mediated via a different domain. And this is something we need to keep in mind when we discuss PCSK9 inhibition via neutralizing antibodies. PCSK9 inhibition leads to increased hepatic LDL receptor expression, leading to increased hepatic cholesterol uptake. This results in a reduced circulating levels of PCSK9, reduced levels of LDL cholesterol in the peripheral circulation. PCSK neutralizing antibodies and small interfering RNAs are now considered second-line therapy for hypercholesterolemia for patients who partially respond to statin therapy or those who are intolerant of statins. The effect of PCSK9 inhibition on the liver is not very clear, and in the remaining of my presentation, I'll try to present the data that are currently available regarding the effect of these inhibitors on the liver. Starting with genetic studies, PCSK9 gene variants, some PCSK9 gene variants have been associated with higher risk of developing hepatic steatosis. I won't go into much detail about this association because different gene variants seem to have different effect on the liver. Another important finding from preliminary studies is that PCSK9 circulating levels are associated with the severity of hepatic steatosis. In this study, 200 patients with MUSCLed, which was biopsy proven, were included, and in this study, increased PCSK9 levels were associated with higher grades of hepatic steatosis, more severe inflammation, and higher grades of fibrosis. These findings were confirmed in a larger study, which included about 700 patients. In this study, steatosis was assessed non-invasively, so there were no liver biopsies. And again, in this study, circulating PCSK9 levels were associated with higher grades of hepatic steatosis. There are two potential explanations for this association. On one hand, PCSK9 might be directly involved in de novo hepatic lipogenesis. And on the other hand, there might be an indirect association. Accumulating hepatic fat might lead to increased PCSK9 synthesis in an effort to reduce cholesterol uptake by the already overloaded hepatocytes. So in summary, PCSK9 seems to be associated with hepatic steatosis. And let's see now what are the data about PCSK9 inhibition. In this multicenter European study, which included about 1,900 patients with biopsy-proven MUSCLed, among those patients, there were patients with PCSK9 loss of variant. And in these patients, the risk of hepatic steatosis and fibrosis was significantly lower. And this effect was irrespective of the known and established metabolic risk factors. This finding was supported by some preliminary experimental data. In studies with male mice that had PCSK9 overexpression, when these mice were fed a high-fat diet, they developed hepatic steatosis, fibrosis, and more severe inflammation. In the lower row, you can see, I'm not sure if okay, so these were the PCSK9 overexpression mice that were fed a high-fat diet, and these were the the wild-type mice that were fed the same diet. So as you can see, the mice with the PCSK9 overexpression had more steatosis, more inflammation, and more fibrosis. This research group proposed a potential mechanism by which PCSK9 inhibition might protect against hepatic steatosis. According to this hypothesis, in steatohepatitis, the liver is infiltrated by neutrophils, and neutrophils produce miRNA 2 to 3 extracellular vesicles. These vesicles are taken up by the hepatocytes, and they inhibit inflammatory and fibrogenic gene expression. This uptake is mediated by the LDL receptor. So when there is PCSK9 inhibition, there is overexpression of the LDL receptors on the hepatocyte membrane, which means more increased uptake of these extracellular vesicles by the hepatocytes, and where they exert the anti-inflammatory and antifibrotic effect. Moving now to the clinical data, which unfortunately are very scarce. One of the first studies came from Greece, from the University of Thessaloniki. This study included 40 patients with heterozygous familial hypercholesterolemia. Among those patients, there were 13 with hepatic steatosis. These patients were treated with neutralizing antibodies, evolocumab or alirocumab, for 1 year. At the end of the study period, there was significant improvement in some of the MUSCLed parameters. In a subsequent study, again with small number of patients, again with familial hypercholesterolemia and hepatic steatosis, they received neutralizing antibodies for 6 months, and hepatic steatosis was assessed non-invasively without any histological data. This study showed again that patients had improvement of hepatic steatosis, and in particular, patients who achieved lower triglyceride levels. One of the more recent studies, again, small number of patients, 29 patients treated with neutralizing antibodies. The treatment period in the study was longer, it was 24 months. And at the end of the study period, 73% of patients achieved radiological resolution of hepatic steatosis and improvement in liver function tests. In summary, these preliminary clinical data are positive. However, there are important limitations, including the very small number of patients included in all three studies, the variable methods by which hepatic steatosis was assessed, and the complete lack of histological data. Now, in the last few years, some researchers have raised concerns regarding the safety of PCSK9 inhibitors regarding the liver. And the reason for that is that the hypothesis behind that is that increased hepatic cholesterol uptake might, in fact, have a negative effect on the liver. Having said that, meta-analysis of 25 randomized controlled trials with 12,000 patients that have been treated with evolocumab or alirocumab have not shown any signs of significant liver injury. There are, however, some preliminary experimental data that support this hypothesis. One of the few studies showed that PCSK9 knockout mice, so mice that expressed no PCSK9, when they were fed a high-fat diet, that they developed severe hepatic steatosis, they developed ER stress inflammation and fibrosis. And these are the PCSK9 knockout mice when they were fed a high-fat diet compared to the wild-type mice when they were fed the same diet, so more steatosis and more inflammation. In this study, the PCSK knockout mice had overexpression not only of the LDL receptor, but also of the VLDL receptor and the CD36. As I mentioned at the beginning of my presentation, CD36 is a scavenger receptor for fatty acids, and its overexpression leads to triglyceride accumulation within the hepatocytes, lipid-induced ER stress, and progression to steatohepatitis. Another study had similar findings. Again, this study included PCSK9 knockout mice that were fed a high-fat diet, and these mice had increased hepatic free cholesterol and cholesterol crystals. And these mice developed more inflammation and more fibrosis. It seems that these preclinical data are contradictory regarding the safety of PCSK9 inhibitors. A possible explanation for this is that complete PCSK9 inhibition in knockout models is different from PCSK9 inhibition that is achieved with neutralizing antibodies. When there is complete lack of PCSK9, there is overexpression not only of the LDL receptor, but also of the CD36 receptor, which leads to worsening of steatohepatitis. On the other hand, with PCSK9 inhibition, with neutralizing antibodies, there is overexpression only of the LDL receptor, and not of without any effect on CD36. As I mentioned previously, neutralizing antibodies bind to PCSK9 at this domain, and they don't seem to have an effect on the domain that binds to CD36. Additionally, it has been shown that PCSK9 neutralizing antibodies increase circulating levels of PCSK9, so there is more PCSK9 in the peripheral circulation. And this means that this circulating PCSK9 might in fact suppress CD36 expression, leading to improvement in hepatic steatosis. On the other hand, it is unclear what happens with PCSK9 small interfering RNAs, which lead to complete loss of PCSK9. In this hypothesis, complete loss of the PCSK9 might in fact result not only in LDL overexpression, but also in CD36 overexpression. And this theoretically might worsen hepatic steatosis. But this is only a hypothesis, and there are no clinical data to support this association. In summary, the association between PCSK9 inhibition, and muscle D is very complex, and it seems that this is a puzzle with a lot of missing pieces. What we know so far is that preliminary data support the role of PCSK9 in muscle D pathogenesis. Preclinical data are contradictory. PCSK9 circulating levels correlate with the severity of hepatic steatosis. The preliminary clinical data, although very limited, support the beneficial effect of PCSK9 inhibitors on muscle D, but there are important limitations. And more data are needed, and studies investigating the effect of PCSK9 inhibitors on this disease that affects 1/4 of the population, and for which there is very limited pharmacological therapy. Thank you very much.